Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by your keynote speaker, Doctor, for today's section. With much pleasure and honor, let me welcome our very renowned Doctor, Dr. Urman Dhruv. Sir is MBBS, MD Internal Medicine, Director of Internal Medicine and Diabetes at HCG Hospital, Ahmedabad. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is approach to a case of newly detected DM. Now, without any further delay, let me welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thanks a lot. Thanks for the introduction. Good evening, everybody. Thanks for being there. And we'll start. What we are going to discuss in next 25 to 30 minutes would be how to approach to a case of type 2 diabetes who has recently been diagnosed. Important things. Before you start venturing treatment or management of a type 2 diabetes patient, you yourself, and for that matter, I myself, should know few particular important things. And this is probably the most important for the management. Diabetes is no more a disease of glucose metabolism. It's a disease where the lipid or the fat starts depositing in the walls of major and smaller or micro arteries. So it's a disease of fat deposition in the walls of blood vessels. And therefore, it is no more a disease having glucose-centric approach. Atypical diabetes is more seen, more understood. Diabetes in the young is more seen, more understood. And the treatment option, most important take-home message in first slide only, the treatment options require screening for established renal and cardiovascular disease prior to initiating treatment. So the message is don't jump to treat. First screen, diagnose, and then analyze. So this is what it is. Previously we were just targeting glucose. Now we have realized that we need to target blood pressure, lipids, heart and kidney, and also the weight. So let's see what is the importance of a first visit. First visit of a case who has been diagnosed for the first time with diabetes. So first of all, try to find out how was it diagnosed, his age-specific history, family history not only of diabetes but also of diabetic neuropathy and premature coronary artery disease, smoking, diet, culture and traditions, occupation and exercise, and his intelligent questions, how much he is going to understand what you educate him. So first and the foremost, is he really a patient who can be stamped with diabetes? The answer is he is diabetes only if A1C is more than or equal to 6.5 with a specific method, or his fasting plasma glucose is more than 126. But caveat, fasting has to be defined with the patient as no caloric intake for at least 8 hours. So if a patient has taken something at 1 o'clock in the morning and is getting his fasting plasma glucose done at 6 o'clock in the morning, it is no more fasting plasma glucose. Post glucose, we all know. And also, another important thing is random plasma glucose more than 200 provided the patient has osmotic symptoms in the form of polyuria, polydipsia, or polyphagia. But more important thing is in the lower part of the slide, and it says that for equivocal result, suppose A1C is 6.5, suppose fasting plasma glucose is 126, borderline, just at the fence, then you require to repeat another test at the same time or the same test after a month, after a week. So if A1C is 6.5, then repeat fasting plasma, and if it is more than 126, now you can stamp him as a diabetic patient. The other way around, suppose fasting plasma glucose is 126, Then do A1C at the same time. More than 6.5 is diabetes. But the other way around, fasting plasma glucose today is 130 and you repeat it after 1 week and it is 121, you cannot stamp him as diabetes. So, first of all, a patient coming to you for the first time diagnosis, then confirm the diagnosis with these parameters. Rule out type 1 diabetes, which is actually not a part of today's discussion, and therefore we'll just mention it. Rule out type 1 diabetes, especially if the patient falls into the age group of 20 and 40 and is lean, then think about type 1 diabetes, keep it in mind. Keep also monogenic diabetes in mind if the patient has been diagnosed as type 2 as diabetes within the first 6 months of life. Look for the drug history, especially of steroids and new generation antipsychotic. Two important drug group which can cause drug-induced diabetes, which is reversible once you withdraw the drug, right? And then comes a very classical presentation from ADA. You can always download it on yourself also, where it says that you require a person-centered glycemic management, meaning thereby you require to provide goals, which you'll see one by another. What do we need to do when the patient comes for the first time? As I told you, confirm the diagnosis and classify diabetes type 1 or type 2. Assess glycemic status and previous treatment if he has taken. Evaluate diabetes complication, very important, because the treatment depends upon whether the patient's kidney is affected or not, whether his retina is affected or not, whether his heart is affected or not, whether he is obese or not, or whether he is having heart failure or not. So many things now decide the type of treatment, selection of treatment, and therefore, before jumping to treat the patient, treat his sugars, look for diabetic complications. Identify care partners and support system who are there at his home. Are there anybody who can take care of hypos if it happens? Does he have a glucose meter? Does he can see properly? Retina okay, vision okay? Can he get up to take a bite of some snacks if there is hypo? Lots of things required. Is he going to get food on time at home? So, very important, his care partners and support system. These are the things which are not there with primary care physicians. They tend to ignore it and then they'll land into trouble, and so are the patients. So, always give enough time and always give enough time before you start looking for the patient. Keep these things in mind and create your own protocol. Look for the risk factors also. This is a busy slide, but we are going to dissect it. But this is a very classical slide which suggests what is to be done by everyone. So, what is to be done? Let's see. Look for the height, weight, and BMI. If BMI falls below 23, well, you have to think about type 1 diabetes also. BMI alone is not enough. You have to look for waist hip ratio on day 1. Measure blood pressure in sitting and standing position both. Lots of patients having type 2 diabetes at the time of diagnosis do have either diabetic polyneuropathy or they have got diabetic autonomic neuropathy, which can lead to postural hypotension. Patient may fall within a week, can sustain fracture, and you are creating problems for him. So on day 1, always measure blood pressure in sitting and standing position. Look for markers of insulin resistance. Very important. Lots of markers are there. We are not going into detail, but the commonest one that we see in Asians is acanthosis nigricans, just behind the neck, or lipomatosis. Always check the pulse at the foot and measure the blood pressure at least once, not always, but at least once in the lower limb, especially if the patient is a smoker. Pulse and ABI, ankle brachial index. Look for the sensations. Look for heart rate variability. Use fundal camera. Even a primary care physician can easily use a fundal camera and get the report done within minutes. and you will be able to know whether the patient is having diabetic retinopathy or not. Same patient is having urinary albumin creatinine ratio positive, in which case presence of diabetic retinopathy would confirm that it is diabetic nephropathy. Palpate thyroid, especially if the patient is between 20 and 40 years of age, because type 1 diabetes and autoimmune thyroiditis go hand in hand. Carotid bruit, renal bruit, HB, edema feet and face, and 6-minute walking test. These are the bare minimum things you require to do in your clinic when you diagnose a patient with type 2 diabetes. Before you go to the next step, which is the investigation for the sake of complication, explain to the patient, educate the patient why does he need to do it. For example, is a new case of type 2 diabetes, go for at least 1 week of self monitoring of blood glucose, 5 or 7 samples at home, or can use CGMS if the patient is affording and educated. Either of them. Why do you need it? Is a newly detected diabetes. You are not starting any treatment. Why should he go for 5 samples sugar at home? 3 reasons. One, he would be convinced that he is really having hyperglycemia even at home. His doctor is not dependent upon one sample, one laboratory figure. So, first and foremost thing, SMBG at home for a week would make him convinced that yes, he is having hyperglycemia. It is not stress, it is not excessive calories that he ate previous night that led to hyperglycemia. These are the excuses our patients have. So get SMBG done for a week before you start the treatment. Once you do it, patient would stick to the treatment always. Second reason is you will be able to know which part of the day is having high blood sugars. Patient can have normal fasting plasma glucose, a reasonably high postprandial glucose, but a very high post dinner, which would allow you to monitor or start the treatment at a particular time of the day. For example, a fasting high would want you to start some treatment for insulin resistance, metformin, pioglitazone. A postprandial high but a fasting normal would allow you to start some treatment which is short acting before lunch, like ripaglinide or voglibose. And if the post dinner is high, you realize that the patient is having more dinner than more the lunch, and therefore the patient should have some drug at night, preferably a long acting sulfonylurea. So, very important thing, first thing is SMBG at home. What messages need to be transmitted? It's a disease of lifestyle modification. Drugs alone may not work for a long time because it is always a gradually deteriorating disease. Drugs can only delay the complication. There is no shortcut. The goal to prevent damage is to target organs. The goal to prevent lipid deposition is statin, and there will be no attempt on the part of physician to change the cultural and traditional diet of the family. These are the messages should go to the patient at the time of diagnosis. That I am not going to suggest you any diet which would change your culture or tradition. Whatever your family is eating, will try to accommodate your diet within that family diet only. You have to tell that your management is effective, safe, and evidence based, and there are long term controlled trials which back it. Always show empathy to the patient. Never tell the patient that it is your fault because you did not walk, this has occurred. Never do it. Put yourself in the patient's shoes. Understand that the diagnosis results in lots of issues: cost of medication, cost of treatment, work changes, dietary restriction, lifestyle changes. Lot of things are to be going to affect his life, and therefore he requires empathy and, very important, gradually stepping up the treatment modalities. On day one, don't tell him that you require medication and so and so and so and so. Just tell him start with lifestyle changes, wait for 1 week, and go for SMBG. Second session next time. Remember that the best diabetologist in the world cannot decide whether he is having diabetes or his diabetes is controlled by standing in front of a mirror. What does this slide mean? It means monitoring, frequent monitoring is the key to success in the management of diabetes. Monitoring not only glucose, but blood pressure, but lipids, but weight, and many more things as we'll see. You will see these are all basic things. Yes, these are all basic things, but this is what we forget to emphasize. We need to tell him that frequent monitoring is necessary, and we should all remember on our own that frequent monitoring is necessary. Many a times we think that if we explain to the patient that he would require self monitoring of blood glucose or frequent investigation, the patient would run away. Well, let him run away after proper education. But if you don't educate, he would never monitor, and then you will end up in trouble. So, monitoring is just like a torch which is required at the time when you are walking in a dark, and you have to look at the torch light also. What does it mean? Monitoring and looking at the reports and then making the necessary changes. That is what the important thing that is required. So, what do we need to do in the second week? Patient has come back with SMBG. He has started understanding diet and exercise. Now we need to investigate him for established complications. So, what are they? Number one, go for A1C. Why do we need A1C? The reason is if A1C is more than 10, it suggests that patient is insulinopenic, at least for the time being. Treating such patient with OHA only can land you in trouble. So you can start with OSA if A1C is more than 10, but only for a week or two. Keep an eye on SMBG, call him back after 2 weeks, and if sugars are not controlled, or if with A1C more than 10 he is developing osmotic symptoms, polydipsia, polyuria, then he requires insulin. Go for lipid profile because it is easy to be done, does not require frequent monitoring, and most importantly, easy and very economical to manage. Statins are very cheap, the doses are very simple, they do not require titration, and statin in a patient of diabetes is even more important than controlling glycemia itself. Liver function tests to look for whether the patient has fatty liver, urine routine and micro, followed by urinary albumin creatinine ratio, especially in females. Why? Because if urine routine micro shows protein plus, you do not require urinary albumin creatinine ratio because it means at least patient has macroalbuminuria. In females, generally vulvovaginitis is very common, which can also lead to positive urinary albumin creatinine ratio. So only after excluding infection or inflammation, a female should undergo UACR. Many of us go for creatinine only, and creatinine is 1.1. We believe it's fine. A patient having creatinine zero point 0.8 and it becomes 1.2, then it is incrementation by 50%, and it means EGFR has fallen from 80 to 40, and therefore measurement of EGFR is more important than creatinine. So EGFR, urinary albumin creatinine ratio, lipids, and A1C, four basic things in addition to blood pressure. TSH in selected cases, sonography for fatty liver and kidney size, resting ECG is type A1 recommendation. CV risk calculator, you can use it from your mobile, just like EGFR, which is also calculated from your mobile. Stress echo or coronary artery calcium score is not required in everyone, but psychological evaluation is a must. So now we have classified diabetes, detected complications, reviewed the previous treatment. Now we should assist in following a management. So how do we go? Before that, if the patient has fatty liver, go for FIB-4 score because that would determine whether the patient is going to develop cirrhosis or not. Very important. Patients having type 2 diabetes and fatty liver are more likely to develop the cirrhosis. So EGFR is a must, and same thing recommendations have been shown here. Now we have to set the goals, which should be smart goals, specific. Then this is smart goal slides, and you can go through it. So goal for weight, goal for lipids, goal for blood pressure, then comes goal for plasma glucose, and then comes the goal for A1C. This is what we have to tell all our patients and document it in your case paper. Glycemic goal should be less than 7, depending upon the age, comorbidity, and also the duration of diabetes. Also looking at the resources available at the patient. Goal is specifically decided by whether we can allow hypoglycemia or not. If you cannot allow hypoglycemia, goal 7 or around is fine. Otherwise, the goal should be 6.5. Positive behavioral changes is important. And now we initiate the treatment. How do we initiate the treatment? First, ask, does the patient have established ASCVD? What is established ASCVD? Angina, myocardial infarction, CABG or history of plasty, peripheral arterial disease in a smoker, stroke, positive stress echo, regional wall motion abnormality on echo, any of these things, or a very high coronary artery calcium score. All these things suggest established ASCVD, and the drug of choice would be SGLT2 inhibitors with or without GLP-1 receptor agonist, with or without metformin, but with, very important, with antiplatelet agents, beta blocker and statin. So, antiplatelet, beta blocker and statin if established ASCVD with now glycemic control with SGLT2 inhibitors, with or without GLP-1 receptor agonist, with or without metformin. So here SGLT2 inhibitors would take the precedence. Then look for whether the patient has diabetic nephropathy or not. How can we detect? By looking at EGFR, which can be calculated from creatinine, and by looking at USER, which can be measured. And then accordingly place the patient in this chart. If the patient has diabetic nephropathy as per the previous chart, which means reduced EGFR and high USER, again start with SGLT2 inhibitors with or without GLP-1 receptor agonist, with or without metformin. But again important here, with ACI or ARB and with statins, ACI or ARB if there is no contraindication. Contraindication include pregnancy or renal artery stenosis or rising creatinine value or hyperkalemia. So, diabetic nephropathy or reduced EGFR with high USCR, SGLT2 inhibitors, but only with ACI, ARB or statins. Does the patient have cardiac failure? How do you know it? His walking time has gone down. Previously, he was taking 2 rounds of a garden. Now he takes only 1.5 rounds. Probably cardiac failure. Patient was taking 45 minutes to take 2 rounds. Now he takes 60 minutes to take 2 rounds. Probably cardiac failure. His ejection fraction is reduced on echo. Cardiac failure. So, does the patient have cardiac failure? Again, SGLT2 inhibitors would be number one drug, but with again the specific therapy, and that is beta blockers, ACERB, with or without diuretics, or Vimda as we call it. Does the patient have risk factors for cardiovascular disease? That is multiple risk factors, MRF. It could be hypertension, lipids, it could be obesity, it could be strong family history, it could be alcohol. Treat as many as you can. But if there are multiple risk factors but not established ASCVD, you can go either with SGLT2 inhibitors or GLP-1 receptor agonist, but with always with statins. Is the patient with obese requiring significant weight loss, or does the patient have associated fatty liver? In that case, the reversal of the role, GLP-1 receptor agonist would precede the use of SGLT2 inhibitors, and metformin would be a part of it, with probably pioglitazone if you can document insulin resistance, but not for weight loss. So this is a very classical chart. You can always download it from any website. This is what we do. We just look for number one, lifestyle changes. Then we look for cardiac failure, established CVD, multiple risk factors, diabetic nephropathy, that is reduced EGFR and positive UACR, and accordingly we select the first drug. And this is how we begin the management of type 2 diabetes. Right? So, initiating treatment, as I told you, can be delayed by 1 week or 2 weeks. It's not urgent, but there are exceptions. These are the time when you should initiate the treatment on day one. Don't wait for screening results. If the blood glucose are more than 300 or 250, start treatment. Osmotic symptoms, polyuria, polydipsia, polyphagia, or classical diabetic ketoacidosis. In all these three circumstances, or type 1 DM, patient requires insulin, at least basal insulin. Infection with type 2 diabetes, insulin. Acute stress, insulin. Or persistent vomiting, insulin. So these are few times which are the places or situations where you should start treatment with insulin immediately and don't wait for the test results. Always tell your patients about these myths or misconceptions. No symptoms means diabetes well controlled. Rubbish. Diabetes means costly investigation. Wrong. I cannot eat rice. Wrong. Insulin is lifelong treatment. Wrong. Why I am treated with insulin while he gets oral drugs? Because you are amongst those few situations where insulin would be life saving. I do not eat, I do not eat sweets, so I cannot have diabetes. Very wrong. Diabetes is associated with weight gain and calories and genes. Fruit juices are safe, not so. Sorry for the wrong spelling. And I have forgotten my medicine. Let me try somebody else's. Never do it. So there are certain myths which require to be busted from day one only. Whenever you treat diabetes, tell your patient you do not require to control glucose alone. You require to control blood pressure, easy to monitor, easy to diagnose, and easy to treat. Very cheap to treat. You require to control dyslipidemia, easy to diagnose, easy to treat, and safe to treat, and very cheap. And you require lifestyle changes. Screening for undiagnosed cardiovascular disease is not required in all cases, only it is required in selected cases. So we can skip it. So start with lifestyle, wait for a week, go for SMBG, add first line of drug depending upon the first week results of SMBG and also upon the first week results of cardiovascular or renal complications. And then think about the second line of drug later on. So, the take home message, understanding the significance of the fact that patient needs to understand reasons behind the management is very important. An initial visit, the first visit, is most important visit as it determines the compliance of the patient with the treatment and also with the doctor. Thank you very much.
Thank you so much, sir, for this wonderful presentation. Am I audible to you?
Yeah, you are audible.
Actually, sir, your camera was off.
Yeah, I'll be doing it.
Yes.
Okay.
Yeah, thank you, sir. So, sir, we do have some question if you like to take that up.
Sure.
So, sir, the first question is, what clinical indicators help differentiate between type 1 and type 2 diabetes in newly diagnosed patients, especially in borderline cases?
Perfect. A very important question. Remember, type 1 diabetes is characterized by autoimmunity in most of the cases. And so you require to document for autoimmunity. Now, the clutch is here. Autoimmunity, that is the antibodies, wane off as the disease type 1 diabetes progresses. So, if you are suspecting type 1 diabetes clinically, which I'll tell you later on, Then go for antibodies, autoantibodies, anti-GAD antibodies at the earliest, because after 2 or 3 years or 4 years, they may disappear and can confuse the picture. So, whenever you suspect type 1 diabetes clinically, go for autoantibodies. Now, question: how do we suspect type 1 diabetes clinically? Number one, age of onset before the age of 18, nowadays before the age of 30. Mostly a female, because autoimmunity is more common in females, but that is not a rule. Number three, generally the patient is not obese. Mostly the patients are lean. Fourth and more important, HbA1c are very high and they are having very high blood sugar or plasma glucose in the range of 250 or 300. Fifth, generally they don't have a strong family history of type 2 diabetes in the family. However, a family history of type 2 diabetes does not rule out type 1 diabetes. And the most important thing is then presence of ketones or osmotic symptoms, polyuria, polyphagia, polydipsia, losing weight, and showing ketones in urine or high ketones in the blood. These are few things that would suggest you that this patient requires to confirm that he or she does not have type 1 diabetes. And how do you confirm? Go for autoantibodies. Second way to do is go for C peptide. C peptide can also differentiate or at least give you a clue that the patient has type 1 or type 2 diabetes. So, a very low C peptide would suggest that endogenous insulin is not synthesized, and that may give you a clue. But go for autoantibodies as early as possible.
Thank you, sir. The next question is, how do you decide on the initial choice of therapy? Lifestyle modification alone versus the initial of pharmacological treatment.
Well, if HbA1c initially is very close to the target, you can wait for lifestyle changes for 3 months. But remember a dictum: during the first year of diagnosis of type 2 diabetes, you should be able to achieve euglycemia, preferably within 3 months. Why? The reason is, higher the euglycemic milieu within the first year, lesser are the chances of microangiopathy and macroangiopathy in future. In other words, if you are watching T20 matches, there is a power play in T20 matches where you send the best of batsmen, not the all rounders. Why? Because you want to have a good run rate. Same way, in type 2 diabetes, try to achieve normoglycemia, that too by normalizing the HbA1c as fast as possible. So, previously the algorithm was 3 months of lifestyle, 3 months of 1 gram of metformin, 3 months of 2 grams of metformin, and then step up the doses. That is now gone. What is required is, if HbA1c is more than 7 or 8, start with 2 drugs and lifestyle changes. Then you can step down the drugs, but start with 2 drugs because you want to keep the normoglycemia as fast or as early as possible. So, how much I would depend upon the lifestyle changes? A newly detected type 2 diabetes coming to me for the first time and is having HbA1c of 6.9 and is obese, then I would wait for lifestyle to take place, changes to take place for about 1 month, 2 months, or 3 months. But I will call him every month to confirm that he is really following the lifestyle and those lifestyle changes are working in the form of weight reduction. But at the end of 1 month, there is no weight reduction. That means lifestyle changes are not working and time to add the drug. So to me, 1 month at the most at present.
Thank you so much, sir. We have one last
Remember,
question.
I'm not saying lifestyle changes are not important, but you require to add drugs simultaneously with lifestyle changes. So don't underestimate the power of lifestyle changes.
Sorry, sir, I thought you have ended that. So that's why I was asking you the last question, which was what role do newer biomarkers play in guiding the management of newly diagnosed diabetes case?
Uh, well, if you are asking me biomarkers, there are very limited biomarkers. You have to still rely upon HbA1c and CGMS, that is time in range. It is not a biomarker, it is basically a blood investigation. So, time in range in CGMS, continuous glucose monitoring system, and HbA1c, along with weight, blood pressure, and dyslipidemia. These are five important things that still determine the treatment modalities in type 2 diabetes as far as glucose is concerned. But then we have to look for heart failure, established stage CVD, and EGFR, USCR also. But at present, there are no biomarkers which can guide the therapy.
Thank you so much, sir, for answering all our questions. That's all from our audience. So, before concluding, any take-home message from your end?
Take home message is, in a type 2 diabetes patient diagnosed for the first time, breathe, take a deep breath, don't jump to treat the sugars. Just give him a time to confirm or to reassure himself, the patient himself, that he is having type 2 diabetes, he is having hyperglycemia. Take time to find out the comorbidities, take time to assess the cardiac and renal risk, and then start the treatment. Unless, as I told you, five or six compelling indications for starting treatment. Otherwise, first week of treatment or first week of diagnosis, wait.
Thank you so much, sir, for joining us today. And it's our pleasure to have you here in our platform. Thank you, sir.
Thanks a lot. Thank you.